Unfortunately, Professor Gupta won't be able to join us. She had a problem and just apologizes to all of you. So I'd like to start the discussion here. We have about 20 minutes for that. So plenty of time to try to clear a few things and get some questions from the audience as well. I think it's very obvious that, with the combined use of these different technologies, we're beginning to understand better which modality is more helpful in monitoring disease, or how we combine them in achieving the best monitoring of the behavior. So it's obvious that if we consider especially the difference between the OCTA, which Francesco spoke a lot about, and the other techniques, more traditional injections that we have, the dyes, clearly there are advantages of the fact that this modality is non-invasive. It's very rapid in terms of obtaining the images, but there are limitations, of course, and that's where exactly we'd like to bring that discussion here. I think that for the uveitis specialist, and Francesco is leading on a paper that we are with Alessandro and Francesco leading on a paper we're about to hopefully publish, exactly analyzing this question about the comparison, how OCTA would compare to ICG, and foreseeing, will it replace it one day, or we're looking at a situation where these old techniques still have a very strong foot in what we do. So I'd like to just discuss a little bit of that, because there are some limitations there. Francesco, maybe you and Aniruddha can chip in this. But we talked about the fact that, of course, without a dye, there's no leakage, so you cannot assess that aspect of the behavior of an inflammatory condition with the absence of leakage. But there are other things that we talked about in the sense of visualization of deeper lesions in the choroid. The chorocapillary look wonderful images, but the choroid, it depends on what's in front of it, what's happening. If you have fluid, you have other obstacles in the way, you may not be able to see as well. So maybe Francesco and Annie, can you guys have a little bit of ideas for the audience? Because these are new techniques. I think people need a bit more of your expertise in guiding when you think it's useful.
I'll go first, Annie, if you don't mind. Dr. Pavesio, you mentioned the lack of leakage. Yes. So if we talk about the retina, which is not the scope here, but in the retina, of course, we look at leakage. So we look at fluorescein angiography. And I think you all know Marion Monk, and she has this beautiful image of an unfast OCTA in a birdshot patient that shows the thickening around the vessel that corresponds to leakage. Apparently, I've never seen it. So in the retina, I still rely a lot on F8. When we go to the choroid, I started shifting a bit towards OCTA. We've been working with Alessandro on 2 papers on granulomas, and we've compared cross-sectionally and prospectively the ICG and the OCTA of choroidal granulomas, and we find a very, very good correlation. So clinically, when I see a patient with either sarcoid TB or VKH that has a choroidal involvement, at baseline, I always get an ICG, but then I also get an OCTA, maybe wide field, and I follow the patient just with OCTA. Maybe every 6 months I get another ICG, but that's what OCTA has given me for now, something that I can really apply in my practice and can change something for my patients.
I think it's a good point you're making about combining the initial assessment, so then you can use the modality just as a way of monitoring the patient, so you know exactly what it means, and then you can see how the patient is progressing.
Because at the end of the day, my patients don't care if an OCTA, there is a small flow void and it corresponds to a small loss of chorocapillaris, and there's another one that there's no flow void, so the chorocapillaris is still intact. The patient doesn't care. The patient wants to be treated. And so we need to be realistic about application of OCTA in our clinic.
Very well. Anything to add?
Yeah, I just wanted to add one point. I think at baseline, if you have an ICG and if you have OCT angio, it's very helpful, especially when you start tapering the steroids and at a point where you suspect that there could be a recurrence, a subclinical recurrence. And OCT angiography can be very useful, in fact, to pick up small lesions which could be a recurrence. And we heard from Dr. Mark Desmet's talk that VKH also, it can recur in the anterior segment. Sometimes it can recur in a very subtle way in the posterior segment, and you can have these granulomas, and you can use OCT angio in your clinic to look if you have flow voids, dark dots. And if I suspect them, I will go definitely for an ICG to make sure if there is a recurrence of the disease. But I think that's a very useful point, that if you suspect a recurrence, or if you're at a point where you need to taper therapy or you need to change immunosuppressive agents, like for example, the patient is non-tolerant to mycophenolate, you're switching agents, and the time period there is very critical, and you can probably get a recurrence. That's where OCT angiography becomes very useful.
Okay, thank
Maybe
you.
I'll
And there
make a
was-
point. Maybe I
Yes,
can make
please,
a
Mark,
point
go ahead.
also, Carlos, if it's
Sure.
okay.
Yeah, sure.
I agree that if you're looking at the choriocapillaris and at the deep retina, OCTA plays a very important role. But if you're looking at the deeper structures, I'm not sure that OCTA at this stage is necessarily the best means of doing it. You know, one of the problems with the choroid as compared to the retina is that it is a dynamic structure that, you know, with each heartbeat fills and empties. And also the RPE presents a barrier to certain OCTs depending on which machine you use. So speed's important to be able to see things. And I wouldn't be surprised that in the future we won't need ICG, but we still, for deeper structures, can certainly depend on it. But I agree, and this is what I tried to show also with these granulomas. Once you have your ICG, you don't need to do it as frequently as long as you can image in the same location. So re-imaging the same spot, being able to target the layer that is being involved is probably the most important thing. And having machines like you have that give you the best OCTA possible at this time in space, space and time.
Yeah, that's a good point. And there was a question from the audience here exactly talking if I had to choose between ICG and OCTA to buy the machine, which one would you choose? So the discussion is showing you that it's actually you would need both to be able to combine and understand better your patient. So it's not a question that one replaces the other. They're mutually useful and helpful, and they help each other in your monitoring and treatment of your patients. The one point of discussion, and that's I'm not going to go into the argument of choriocapillaris because I agree with the assessment of mutes. I think the choriocapillaris looks pretty much intact when you look at your OCTA images. The point here is exactly is this the RPE or the photoreceptor which is causing the trouble here, and where is the problem? And many years ago I wrote a paper with Roberto Dell'Uomo when we talked about why is the fluorescein different in mutes comparing to the other conditions. So we see early hyperfluorescence in mutes in fluorescein. In the others, you see early hypofluorescence. So that already gives you a clue that the process is not the same, that there's something different in the way these two conditions or this group of conditions are behaving. And one aspect to analyze is that we thought the RPE would be the reason why that was happening. And Francesco's explanation about why the fluorescein, why the hypofluorescence on ICG in conditions in which you have involvement of choriocapillaries because the RPE is not taking up the ICG and looking dark. And the same argument used reversely for the fluorescein. I think the RPE is getting loaded with fluorescein in a different way, in shining in a way that is showing that early hyperfluorescence. I'm not sure if you guys agree with that assessment.
Yeah, definitely. So when we did the study with Saraf on mutes, we were looking at a lot at OCT and on FAS, and we thought it was probably a disease of the photoreceptors. But then Stavrengi's group from Milan, they had a very nice paper on OAI about how it could be a disease primarily of the RPE. And I think I kind of agree that it's probably primarily in the RPE, but at the end of the day, it doesn't really make a difference to me or my patients. I still think I'm quite convinced it's not a disease in the choriocapillaris or the choroid, which is probably the most important part. That's why it's called the common cold of the eye, because it's quite benign in most of the cases.
Yeah. No, I think many features are different in the sense of how it behaves and how it resolves in a very different way from the others, in which you end up most of the times with the outer retinal damage, which doesn't happen in the recovery of mutes. And you mentioned very well, the disorganization of the photoreceptors in the areas affected is responsible for a lot of the imaging changes that we observe in our patients, and that recovers over time. That's why we see the
That
improvement.
could also be,
Mark.
you know, RPE disease. You lose your tight junctions, so fluid, you know, fluorescein from the choroid could come into the deeper layers. And I think a disease of the RPE will in fact allow fluid and proteinaceous materials to get into the deeper retina. So it could be, you could still see on OCT the changes you're seeing. And if you look at active multifocal lesions, they tend to be more at the level of the choriocapillaris, and then they cause these bubbles that form in the deeper retina that extend into the inner retina, inner plexiform layer. And I think, you know, as the disease regresses, all of this disappears. So I think we have to also look at, you know, the dynamics of what can happen at that level. So I would go more for RPE.
Okay, agreed. Thank you, Mark. There was a question from the audience here. Has serpiginous choroiditis been associated with sarcoidosis? So Annie, you might be able to answer this.
There are reports that sarcoidosis has been associated with serpiginous choroiditis. If you listen to Professor Narsingh Rao, I remember in one of his lectures, he attributed 3 reasons for serpiginous choroiditis. One is TB, viruses, and sarcoidosis. But to be honest, in our clinical practice, we have not seen sarcoidosis causing serpiginous choroiditis as an etiological factor in our patients. We somehow don't find a direct sort of an association. So there are reports, I don't deny that, but I have not seen any patient of sarcoid presenting with serpiginous. The usual manifestations I see are vasculitis and granulomas, apart from conjunctival involvement. So how about the others? Have you seen any? I haven't really seen any.
No, I have not seen a case that I would say was a serpiginous induced by sarcoid. What we have to keep in mind, well, Mark?
No, I haven't either. I think, you know, PIC and multifocal is different. There I have seen that, you know, progression, but never in serpiginous.
Yeah, I think the one thing to remember is sarcoid is in a way can be, of course, I think sarcoid is a syndrome rather than a disease, and it can be a spin of TB. So you may very well find the TB evolving into a sarcoid behavior depending on the immune response of the host. So it may be that in some cases that you have to see those reports, Annie, but it may be that this is the potential confusion there. It could be that TB was the core of the stuff and then induce changes which are also compatible with sarcoid, which we see very often. So I'm just speculating here, but it's a possibility.
Maybe I can make one comment about serpiginous, because Vishali made the point that in serpiginous, it's always bilateral. And, you know, the lesion she showed is a fairly large lesion. But at the very early stage, there can be a lot of it can be asymmetric. And so sometimes you just see a little bit of a lesion in one eye, and it might even be absent. And so following over time may help you to better define exactly the disease pattern. So, you know.
Just like to add one more point, which is childhood sarcoidosis, which is one of the entities, which is Blau syndrome. That can be associated with chorioretinitis patches. They're not typical serpiginous-like, but that is definitely associated with these patches of choroiditis.
Okay. Mark, there's a question here which probably can go to you because you talk about more the stromal. It's what are pathognomonic signs of BKH? Bilateral exudative retinal detachment, optic disc swelling, thickening of the choroid, cells in the anterior chamber. Is this sufficient to make the diagnosis?
Well, the cells of the anterior chamber are usually not present in the original acute stage. In the acute stage, you'll see the retinal detachment, a very proteinaceous subretinal fluid. You might see even some proteinaceous membrane under the retina. The typical choroidal thickening that we showed, as well as these pinpoint lesions on fluorescein. The optic nerve may be involved, certainly if it's very diffuse, but it's really the retinal changes that are typical. And then as these regress very quickly, they can either recur, as was mentioned, and most of the time you see the anterior chamber involvement when you get chronic disease that involves the iris, and the iris very often loses its crypts. You start seeing some granulomas at that level. And if the iris becomes too thick, you'll start having glaucoma, but that's a much later, this is more of a chronic stage.
Vishali presented a case, two cases that were very interesting. I just want to make a comment. She's not here, unfortunately, but she presented that case of the toxoplasmosis, which was confused with a choroiditis initially, and then treated. And she said the patient was immunocompetent. But we have to remember that patient received an IVTA and also was using oral steroids. So that individual was turned into an immune deficient individual, at least locally in the eye, with that IVTA. And that's just to highlight the point we always make about do not treat an infectious disease in the eye with a depot injection, because the result is usually disastrous. So that's a good example of that. And this confusion can lead to the wrong decisions. If you don't really identify the retinal involvement, you conclude it's only choroidal, then you may make the wrong decisions. Francesco, you had your hand up and then you put it down again.
Yeah, can I ask Professor Desmet a question? So he mentioned that in birdshot, ICG and FA are paramount because they choroidal and retinal involvement, they are not always, they don't go side by side, they're independent. Do you feel it's the same in terms of treatment? So sometimes when you treat these birdshot patients, you see a choroidal response, but not a retinal response. And so, and also, do you get FA and ICG more often in birdshot patients?
I use it essentially to try and diagnose the involvement, because with birdshot, the difficulty is you don't see much inflammation. And historically, patients with birdshot within 5 to 10 years would become blind because we didn't treat enough. So to me, if I see involvement of the choroid or involvement of the retina, I want to get rid of that involvement. And if I can follow it with choroidal thickening, if OCTA can help me or some other modality, then I'll use that, but I'll try to be as aggressive as I need to be to get rid of that disease. And we talked about multimodality in some ways with OCTA. And for birdshot, for me, doing a visual field and getting electrophysiology is very important, knowing if the patient has any kind of night blindness, because all of these features will help me know a little bit the stage of the disease and how aggressive one has to be. But ideally, you want to be able to eliminate the disease. That's number one. So, with biologics, with, a combination of let's say, calcineurase inhibitors or other. And then once you reach a stage where there is no disease present, somewhere between 3 and 6 months later, I'll try to reduce the dose to the minimum dose necessary to see no change in any of the parameters. But as you, and I think most uveitis experts, we prefer not to use invasive imaging techniques using contrast if we don't have to. So for birdshot, I try to find whatever will help me, whether it's a visual field, whether it's electrophysiology, or just the OCT before I repeat the angiograms.
I think an important point I want to make here, time is beginning to run short now, but I think the point that you guys have made in the course of these presentations in terms of the choroid, VKH, when you treat initially, patients respond with a serious detachment disappearing, vision improves. Birdshot, you get rid of the vasculitis, your patient feels happy. But if you forget the choroid, the disease will have a very bad outcome. So we cannot be satisfied with the resolution of the acute problems that led to the symptoms and presenting symptoms. You have to be aware that the pathology is still happening. And if we are not taking care of the choroidal inflammation aggressively, the result will be a bad outcome, as you, Mark, talk about birdshot, and we know very well about VKH. And the issue of treatment is important because they can respond differently. I think the choroid and the retina will respond differently. The vasculitis may respond very well to local therapy, which does not really improve the behavior of the choroid, which then requires systemic therapy. So strategies are combining therapy sometimes to be able to achieve a good balance between local and systemic, reduced burden of exposure, but always keep in mind that if you don't shut down the choroidal inflammation, you're having trouble, not immediately, but in due course. So it's a question of making sure that is clear in your mind when you treat your patients.
And it's the one we usually miss because we're not looking for it. So we have to do that. That's the important.
No, absolutely. I think it's all that we're highlighting here today is important to bring to people's minds the fact that we have several tools now that are allowing us to look into the choroid. is no longer an accessible layer. We can see it. We are learning how to look into it. We're learning how these different techniques can be used to interpret the findings and how they can be used to combine to monitor disease progression in response to treatment. So I think this is an important message to everyone about these conditions. I don't know if any of you has any final comments to make before we wrap up the session. Francesco, Annie, Mark, any final thoughts?
Maybe one final one about the toxo is that, you know, the image that we saw with Vishali reminded me of our immunosuppressed patients with AIDS. And in the AIDS era, toxo lesions looked like viral infections, very much like CMV. So if you see this image, think about toxo, because it could be, you know, steroids is a form of immunosuppression. You'll see some patients certainly that have been immunosuppressed for other reasons. And it is a little bit like syphilis, a bit of a mimicker. It mimics other things, particularly viral infections.
I think the moment you see a retinitis, think infection. Really, don't be fooled by just using immunosuppression, because there's a great chance that this process is an infection or eventually an infiltration of the retina. I think we are pretty much on time here to wrap up the session. I'd like to thank all of you, Mark, Francesco, Aniruddha, for your excellent presentations, and Professor Vishali Gupta, who couldn't join us at the end, but gave us an excellent talk. And we hope to see everyone in person at the 2023 SOE meeting in Prague. So thanks, everyone, and have a good weekend, and hope to see you soon. Take care.
Thank you very much.
Thank you.
Bye.
Bye.
Thank you for the invitation. Bye.
Bye.